respected chairpersons on the dais, senior colleagues and friends, good afternoon. I'm going to talk in this SICS session of update to upgrade. So if you are a SICS surgeon, you should upgrade and start using premium IOLs. If you don't want to update to phaco, I won't say upgrade because both surgeries are equivalent, both surgeries are good. So when I say upgrade, you may feel that phaco is better, but it is nothing like that. Both are good. But if you want to update your skills, then you should start using premium IOLs. Our wish as a cataract surgeon is always to give 6x6 and N6 vision to all the patients and clear cornea on day one. And I'm sure that we can achieve clear cornea on day one in all cases of SICS. Though I am a 95% phaco surgeon, I won't say that I will give 100% clear cornea on day one. So I'm going to talk on SICS with premium IOL. I do not have any financial interest in any of the products mentioned in this talk. When you talk about premium IOL and implantation of a premium IOL, which essentially means either a multifocal IOL or a toric IOL or toric multifocal IOL. So it is not only a science, but it's an art, and it goes beyond evaluation of the eyes of the patient. It takes into account personality of the patient and specific requirements of the patient depending on his or her occupation. It also involves in challenging explaining intricacies of premium IOL technology, because if you say that I'm going to put multifocal IOL, patients' expectations will reach sky high. And if those expectations are not met with, then patient will be an unhappy patient. Though patient may get 6x6 and N6 vision unaided, but patient satisfaction will not be there. After considering all these preoperative things, then comes the most important thing of performing a surgery, which is a next challenge. And if you are doing SICS and if you want to implant premium IOL, it is really challenging. See, whenever we attend conferences and whenever we see prolific surgeons showing you some gymnastics, it is not in day-to-day life that they are also doing in every case that way. And they have reached that level after doing so many surgeries. So your take-home message is not that from next day onwards you just start copying that surgeon and start performing the same way. You have to evolve your own technique. You should, there is something like SWOT analysis. You should know your strengths, weaknesses, and other things. So first thing is that points which we should consider before putting premium IOLs are, what is the need for a premium IOL for that patient? You have to talk to the patient, you have to give chair time. Enough chair time should be given. If you talk to the patient, then patient will not be unhappy. You will realize his expectations and you will tell him the realistic outcome. And then you have to decide choice of premium IOL, whether multifocal should be used or extended depth multifocal should be used or trifocal or toric multifocal has to be used. Another thing is preoperative examination of the patient. If you're thinking of putting premium IOL, it is most important. Look for dry eyes, because you may do perfect surgery, but if patient has dry eye, then patient will be unhappy patient. Watch and examine preoperative astigmatism thoroughly. You should know your surgically induced astigmatism. You should be perfect. It should be repeatable. When I do phaco, I know that I will induce so much of astigmatism when I perform surgery. Same thing, you should be confident that you will be inducing so much of astigmatism in particular axis. But unfortunately in SICS surgery, there are multiple factors which decide surgically induced astigmatism. In phaco, there are very less factors. But in SICS, there are the wound construction, the tunnel construction, the depth of tunnel. There are so many things. So every time the surgically induced astigmatism may not be same. Surgically induced astigmatism also depends on location of incision and whether you are using the astigmatic neutral funnel. Then comes most important, removal of nucleus from that small incision, whether like Professor Kamaljeet has shown 4 millimeter incision. So a grade 4, 5, 6 cataract you cannot remove, everybody cannot remove through that. So if patient with that grade asks for premium IOL, you should tell him realistic outcome and you should not tell him something which is not going to be achieved. Patient selection is most important. Just avoid demanding, hyperactive, critical, type A personality. Just avoid that patient. Patient with irregular astigmatism, avoid. Previous history of refractive surgery, penetrating keratoplasties, avoid such patients. Zonular dehiscence, don't do premium IOLs. Those who are driving at night, those who are in profession who want to drive at night, avoid those patients. And those patients who have strong desire for spectacle independence, give them realistic outcome and their expectation, try to understand their expectation. A thorough routine clinical examination. Important point in this is the accurate biometry is of utmost importance. You may do perfect surgery, you may remove hardest of the nucleus through smallest of the incision, but if your biometry is wrong, then everything goes haywire. Surgical technique. In surgical technique, क्या हो रहा है यार? Slide पुढे का नहीं जाते? Next करते हैं ना slide. हाँ, okay. Capsule Axis is important in if you are planning a premium IOL. A perfect capsule axis is a must. See, when we perform SICS, we have an advantage. Even if you are not able to perform proper capsule axis, still you will be able to do perfect surgery. But if you want to implant a premium IOL, effective lens position is one thing which is of most importance. And to achieve that effective lens position, your capsular axis has to be perfect. It should be of adequate size. Lahane sir has already explained that if it is very small, accidentally you may remove entire lens instead of removing only nucleus. Proper centration of capsular axis is most important. Tunnel construction, the next step, it is also very important. The tip for proper tunnel construction is that your blade initially should be perpendicular to the sclera. The depth has to be 50% of the scleral thickness. And the incision should be either frown shaped, chevron shaped, or inverted bat wing. Inverted bat wing means you have seen so many videos of sir as well as Ragini madam. All those incisions are inverted bat wing incisions. And it should be in astigmatically neutral funnel. Then you will induce less astigmatism and you will be consistent in your surgical induced astigmatism. So as I said that surgical induced astigmatism is most important. It is multifactorial in manual SICS as compared to phacosurgery, and surgeon should be confident and consistent in achieving the same good results. Now comes the nucleus delivery or nucleus management. Now hard nucleus, large nucleus, removing through a small tunnel is really challenging. So there are certain minification techniques which are used. This is Snare Technique, and we are proud that a surgeon from our own Maharashtra, from Nandurbar, Dr. Anil Shah, has developed this technique almost 30 years ago. He uses steel wire to make a snare, and he cuts hardest of the nucleus into smallest of the pieces, and he removes all those smallest pieces through the smallest of the incision. But everybody cannot achieve that. You have to achieve that level. Another thing is my loop. It's a Nitinol loop. It is actually, I will say, similar to the technique of Dr. Shah, Anil Shah. And Nitinol is an element which is made of nickel and titanium of 300 microns, and it has good elasticity, good memory, and good cutting power. advantage is that it goes through 1.5 millimeter and expands to almost 10.5 millimeters. And it can be used inside the back for cutting the nucleus. Another technique developed by Dr. Sudhir Singh from Mount Abu is Nucleus Fracture, intratunnel fracture technique. That is also good. So ultimately, as a surgeon, you have to develop your own technique to minimize the nucleus and remove hardest of the nucleus through the smallest of the tunnel. Another good way of managing astigmatism is customized incision cataract surgery. This surgery is popularized by Dr. Boramani from Mumbai. And most of the prolific SICS surgeons perform this. They take incision on the steep axis, and since they know that surgically induced astigmatism is X, so that they can neutralize that particular astigmatism if we take that incision on the steep axis. There is another technique which is a software-based technique developed by Dr. Raut. He is a surgeon from Pune, but I do not have personal experience of it. And that is also good, that's what he claims. One should have a strong intraoperative exclusion criteria. Even if you have promised a surgeon of doing a premium IOL, you should be bold enough to exclude case if you face an extension of capsular axis to periphery, if there is too much of eccentric capsular axis, if there is accidental damage to zonules, if there is trauma to pupil during surgery, and if there is vitreous loss. To summarize, proper understanding of needs of the patient and selection of premium IOL technology is a must. Preoperative counseling and sufficient chair time should be given by the operating surgeon. Surgically induced astigmatism of the surgeon has to be properly analyzed before venturing into premium IOLs in manual SICS or even in phaco. To choose premium IOL wisely according to the need, the current refractive error, and demands of the patient. Every patient may not be a suitable candidate for premium IOL due to his condition and demands and limitation of current technology, so you have to explain it to the patient. So always under-promise and over-perform. I thank you, and I thank again for giving me opportunity to share my thoughts. Thank you.